All right. Good morning, everyone. Hope you all are doing great. I am excited to get started today. We are going to get started in just about 5 minutes. If you don't mind pulling up your chat box and saying hello, where you're logging in from, I'd love to get to know each and every one of you. All right. I appreciate you all joining a little bit early today so we can get started right on time. If this is your first time joining one of these webinars, go ahead and type in yes and your name so I can know you. That would be wonderful. Welcome to all first timers. Awesome. Nidhi, Sloan, thank you for joining. Again, if this is your first time, I'd love to hear from you, get to know you a little bit. Welcome to the HyGuru family. Thanks so much for joining today. So Madila, hey Ahmad. All right, I hope everybody can hear me and see me. Welcome, everybody. Good morning. If you're just getting in here, please say hello in the chat box where you're logging in from. Welcoming those who have been to my prior sessions as well. Thank you so much for joining again. We're going to get started in just a little bit. All right, those logging in from YouTube, go ahead and say hello and where you all are logging in from. All right. Hey, Shamim, Kumil, Chuka, PL, YM. Excellent. What an international audience. This is great. So glad you all are joining me. Let's go ahead and get started in just about a minute or so. Awesome. Hey, Hoon. Great. Well, if you're just joining me, feel free to say hello in the chat box. And you can also turn your Zoom chat box from the setting of hosts and panelists and switch it to everyone. We're going to have so many active recall session or questions today, as well as multiple choice questions. So I'd love for you all to participate. Again, if you're just joining, say hello in the chat box. Welcome and good morning. For sake of time, we're going to get started a little bit earlier now, and it's just about 10 o'clock. So let's go ahead and get started. I want to welcome each and every one of you to the second session today, the second organ system. We're going to be covering respiratory microbiology, and this is part of my integrated microbiology for the USMLE. Many of you have seen my NBME top concepts, have also seen my images, webinars, have also seen my pass-fail course and have enrolled in it. And I'm going to give you some information on that as well. But I see many first-timers, so I do want to introduce myself. My name is Rahul. I'm currently a pediatric critical care physician. I'm also pursuing my master's in medical education. And over the past 7 years, I've been absolutely passionate about helping students just like you prepare for and excel on the USMLE. Can't wait to share my passion with you today. And I'm going to be going through over the next couple minutes as to what makes HyGuru so unique. I know there's so many resources out there, but I just wanted to share with you what makes my little baby HyGuru so unique. HyGuru is an evidence-based approach to USMLE preparation. And I really focus on three things. And this is what makes HyGuru so different. I focus on teaching in an active recall manner. Many of you have heard this word active recall throughout your medical journey, and I believe that it is one of the most effective ways to learn USMLE material. But it's not about learning material in different silos. It is about making connections, because once you make connections in the hippocampus, you can augment your memory. And so one of my key approaches is to integrate material across organ systems as well as across different domains. And we'll be going through some of those integrations today. And then finally, I've really leveraged the power of test-taking strategy. I think that having a sound approach to various question types on the USMLE is the way to go for both Step 1 and Step 2 CK. And my ultimate goal is to make sure you all think like the test maker. So when I prepare students all around the world, I focus on this triad, and that is making sure that you can integrate content and learn content. We put it with the scaffolding of test taking. I focus on productivity and scheduling, and that's why I have many study templates that you can check out on my website. And I think one thing that sets me apart is that I focus on test taking psychology. As you all are preparing for the exam, it is somewhat of a mental battle and a mental challenge. And addressing that is something that I find very innovative. And I'm so glad that you're joining me today for this inspirational webinar. We have over 80 people joining us today, and I'm so glad to say that HyGuru is a community. I've been humbled to teach across the country and give talks all around the country, teaching at some very top tier medical schools, both live, and now we have transitioned to a little bit more of an online community. And I'm so glad we're all lifelong learners in medicine going for this important USMLE exam. So I do want to share with you a very special course that I continue to improve each and every day, and that is my pass-fail course. Many of you on this webinar have already joined my pass-fail review. However, for those of you who haven't and are still preparing for the USMLE, I would highly encourage you to enroll, and I'll give you some details at the end of this webinar. But without any further ado, I do want to get started with today's webinar, going through respiratory microbiology for the USMLE Step 1. Ladies and gentlemen, if you are ready to get started today, can you type in yes into the chat box, please? Excellent. Bianca, Deepak, wonderful. Well, let's go ahead and get started with the overview. In our last session, we went through an introduction to microbiology, as well as covered cardiology. Today, we are going to be covering respiratory. Why did I create these webinars? Well, remember that microbiology is about 10 to 15% of your USMLE Step 1 exam, and many questions related to micro also flow into content points related to immunology. I also want to note that in terms of physician tasks and other content domains that the USMLE likes to put in micro is under the auspices of multi-system processes and disorders. And that's why I find today's webinar very important. One disclaimer before I go on, I want this webinar today to be a focused, active recall, fun, integrative review. And I ask for just about 1 hour of your time today. I'd encourage you to just cut out any distractions, close out any tabs that you're not using, and just focus. Have the chat box up so that we can engage in a conversation and I can help answer questions, especially towards the end of the webinar. So the goal of this series of webinars is to take some high yield points you're learning from Sketchy and apply it. My goal is to make sure that I show you how does the NBME and the USMLE like to test some of these microbes. One of the key features of today's session is going to be taking microbes and integrating them in this table. We're going to be going through the organism. What disease does the organism cause? Remember, USMLE questions do focus on this second column because they're going to present the disease and then ask you about the microbiology. They may also ask you about various lab characteristics or morphology characteristics. They may talk to you about virulence factors. And I think that this is extremely high yield because USMLE step 1 compared to USMLE step 2, step 1 is a little bit more of a mechanism-based exam. Also, understanding mode of transmission as well as pharmacology integrations will be important for microbes, and we'll be building this table throughout the webinar. I do want to give you a little bit of a study tip just for you to improve your microbiology performance. Anytime you see a microbe, whether it is in a test question or while you're studying, I would encourage you to actively recall the morphology or the lab characteristics, because sometimes the USMLE likes to go for those two-step thinking questions and wants you to not only recall the name of the organism, but actually how to identify the organism. So here's today's overview. I ended up breaking down respiratory microbiology into the microbes that affect the upper respiratory tract and the microbes affecting the lower respiratory tract. Today, we're going to be going through various bacteria: strep pneumo, Hib, Bordetella, Legionella, Mycoplasma. We're also going to be going through various viruses: coronavirus, orthomyxo, Picorna viruses. And we're going to touch a little bit on systemic mycoses, but we'll save that for future sessions. So let's go ahead and go through respiratory microbiology. I always like to start out with a little bit of a warm-up question. A 28-year-old male presents with fever, cough, and rhinorrhea. He is noted to undergo nasopharyngeal swab testing. Non-enveloped, naked virus particles are extracted. They contain RNA molecules which subsequently undergo translation to create virulence in the upper respiratory tract. Which of the following is the most likely pathogen behind this patient's symptoms? I'd encourage you to open up your chat box and switch your setting to everyone and type in your answer into the chat box. A, influenza A, B, HSV, C, rhinovirus, or D, RSV. What do you all think is the answer here? Excellent. I'm seeing a lot of answer choice C, and you're absolutely correct. This naked RNA virus that causes an upper respiratory tract infection is going to be rhinovirus. So when we think about upper respiratory tract infections, especially acute respiratory tract infections, they're going to be affecting the nasal cavity all the way down to the larynx. Again, this is not going to be in the lungs. And so key things that you're going to see on your USMLE questions: these patients are going to have mild fever, nasal congestion, also known as rhinorrhea. They're going to have sneezing. They're going to have sore throat. And what's important, whenever you're seeing fever plus a sore throat, you should say the words pharyngitis. And pharyngitis can be stratified into exudative and non-exudative. And we're going to be going through that a little bit later on. But again, it's all about making these mental frameworks. These patients are going to have a cough. It could either be productive or non-productive. But because this affects the upper respiratory tract, you're going to have clear lung sounds. You won't necessarily have crackles or wheezing because it's only affecting the upper airway. Usually, USMLE questions in the physical exam may also allude to transmitted upper airway noises. indicating that there is some pathology or infection in the upper respiratory tract. Another important thing for us to recognize, especially with URI, is integrating a little bit of public health sciences for your USMLE. And remember that when the prevalence of a disease is going to be equal to the incidence, that is going to be during diseases that have short duration. So what that means is that we see the common cold pretty prevalent in the population. So new cases add to the prevalence. And so incidence and prevalence are going to be somewhat of the same, especially in diseases that are like the common cold that are going to have short duration. So when we think about the common cold, let's go through some common pathogens: rhinovirus and coronavirus. Remember the morphology of rhinovirus and coronavirus, they're single-stranded positive RNA viruses. And key USMLE features that I just want to highlight, especially related to coronavirus, is COVID-19. Remember, COVID-19 has been in the news for causing not only upper respiratory tract infections, but also lower respiratory tract infections. Characteristically, questions may have an alteration in taste or smell, as well as signs and symptoms of lower respiratory tract disease, whether that's going to be pneumonia, interstitial infiltrates, or even as severe as ARDS. Now, when it comes to specifically rhinovirus, let's go through the table integration. Here we have rhinovirus, which typically causes the common cold. It is part of the Picorna viruses. So what are other viruses in the Picorna virus family? Go ahead and type that into the chat box. What are other viruses besides rhinovirus that are going to be in the Picorna family? Go ahead and type it into the chat. Awesome. Wonderful. Many people are saying echo polio. I like to remember the mnemonic PERCH, PERCH, and that is polio, echo, rhino, Coxsackie, and Hep A. Remember, with regards to rhinovirus, it binds to ICAM1. And this is how it is going to enter into the nasal epithelium. I think this is a very high yield point, understanding which viruses have tropisms to specific receptors. The mode of transmission is going to be respiratory droplets as well as fomites, so contact. And that's why things like regular sanitation and hand washing is going to be important. Pharmacology integrations is the fact that we don't typically use antibiotics. This is a self-limiting disease. All right, let's go ahead with our second question. A research study is focused on virulence factors for human influenza A virus. The patients in the study undergo respiratory tract epithelium biopsy. Which of the following proteins, if isolated in the respiratory tract epithelium, would confer primary infection in patients? A, antigenic glycoprotein, B, cholesterol capsule, C, polysaccharide capsule, D, ICAM1, or E, RNA polymerase. What do you all think is the answer here? Wonderful. If you're thinking about human influenza A hitting an antigenic glycoprotein, you are absolutely correct. Remember that it is going to be the HA, which is the hemagglutinin, that is going to be very antigenic and bind to the host sialic acid bond, which is going to be right on the host epithelium. So let's go ahead and talk a little bit about how you differentiate on the USMLE common cold versus influenza. Remember, common cold, also known as upper respiratory tract infection. The common cold in your test questions, again, are going to have mild fever, nasal congestion, cough, however, no body aches. The key to influenza on your USMLE is to recognize that patients with influenza have high fevers, headache, and myalgias or body aches. This is very important for you to note regarding flu. Patients may have some mild nasal congestion and cough, but watch for the myalgias in your history of present illness. Another important point for us to recognize is that influenza is going to need alcohol-based sanitizers, and that's because these alcohol-based sanitizers are going to degrade the envelope of influenza. So let's go ahead and go through the table integration. Influenza, it causes flu. We also have to worry about superimposed pneumonia. And I want you to tuck this away in the back of your mind, but typically patients who get superimposed pneumonia after the flu are going to have this biphasic response. They're going to present sick, they're going to get a little bit better, and then they're going to get acutely worse. Remember that influenza is part of the Orthomyxo family. It is a negative sense RNA virus that is segmented, and it is enveloped, and that integrates back to the alcohol-based prevention that we talked about. In terms of virulence, it has hemagglutinin and neuraminidase. Remember that the hemagglutinin is going to be important for entry into the host cell, whereas neuraminidase is going to be leaving. So entry, HA, leaving, NA. Mode of transmission typically is going to be via respiratory or fomites, and the pharmacology integrations are the following. Remember that we undergo a humoral response to the hemagglutinin, and it's the hemagglutinin that binds to the host cell. So we make antibodies with the flu vaccine. Another important thing for us to note are neuraminidase inhibitors. Now, remember, these are going to prevent virion release from the host cell so that the influenza can't go to other host cells. And this is typically what we call clinically Tamiflu. So Tamiflu is going to be oseltamivir. There's also zanamivir. These are anti-flu agents. Another integration that I want to make related to flu is talking a little bit about epidemiology, specifically genetic shift and genetic drift. Which one is a little bit more severe? Well, I would say genetic shift. I say, oh shit, it's a shift, which means that there are two virus strains, let's just say from swine and human, that infect the host cell. And now you have RNA reassortment to create a new virus. Genetic shift is one of the epidemiologic basis for pandemics to arise. Now, genetic drifts are going to be random mutations, not necessarily co-infection, but random mutations in some sort of structural component of the virus itself. In the case of flu, hemagglutinin and neuraminidase. So just to hone in here, that when it comes to hemagglutinin, it binds to the host sialic acid, which is on the phospholipid bilayer. When it comes to the neuraminidase, that's going to promote your progeny release. And this is where your oseltamivir and zanamivir are going to act. All right, let's go through this question. Before we go on, is everybody learning something? Go ahead and type in yes into the chat box. Excellent. Minchu, John, Alan, Ahmed, Abhinav, Bianca, y'all are doing great. Everybody's doing awesome. Let's go ahead and go through this question. Make sure your chat box goes up. A 30-year-old male presents with fever and shortness of breath. He was seen at the urgent care a week ago as he was having runny nose, cough, congestion, fever, and myalgias. The patient endorses headache. Physical exam is notable for no neck stiffness. Respiratory exam shows left-sided crackles. A chest X-ray is notable for two lobar opacities in the left chest. Which of the following pathogens is the most likely cause of the patient's symptoms? A, strep pneumo. B, moraxella. C, staph aureus. D, non-typable H. influenzae. Or E, Klebsiella. What do you all think is the best answer here? Wonderful. And I would encourage you all to participate. Let's go through this question real quick. Remember that the patient had a prodrome of flu-like illness and then subsequently ended up getting worse. The patient had pneumonia after the flu. Most common etiology is going to be C. Staph aureus. What's also important for us to note, and this is seen in my test-taking strategies class, is that the patient had headache and is seeming a little bit more sick. But USMLE questions end up putting at times pertinent negatives. And you'll learn this in my test-taking strategies class, but pertinent negatives rule you away from certain diseases, i.e. the no neck stiffness means that there's no meningeal signs, and thus this question is not related to things like Neisseria meningitidis, for example. All right, let's go through this active recall question. What is the likely diagnosis? A patient presents with runny nose and fever, so he has signs of URI symptoms. He had a URI for the past 7 days, but it doesn't seem to go away. The patient now has pain in his maxilla. Vital signs are notable for a temp of 103, so he's febrile. Lung sounds are clear, and again, a nice pertinent negative telling you that this is an upper respiratory infection. What do you all think is the diagnosis? Go ahead and put your answer into the chat box. Excellent. Anapala, Minchu, everyone who's saying that this is going to be sinusitis, you're absolutely correct. Remember that when you have a URI that is going to persist and then cause pain, especially in that trigeminal distribution, you're going to be thinking about sinusitis. Now, what's a severe central nervous system complication of sinusitis? That is going to be frontal lobe abscesses. And the USMLE just likes for you to know that this is going to be due to extension via the ethmoid and cribriform plate. Another important CNS complication that I want to integrate here is a CNS complication related to otitis media. Remember that otitis media can cause you to have mastoiditis. And this is the same type of pathophysiologic mechanism, extension of infections. So otitis media, middle ear infection, it can hit the mastoid air cells. You can get pus that accumulates right in the mastoid bone. And subsequently, that can cause proptosis of the ear, and patients can be very sick. They can even have temporal lobe abscesses as well. So again, understanding source of infection, very important as you go through USMLE infectious disease questions. Let's go ahead and review sinusitis. Acute bacterial sinusitis. As you can see, there is maxillary opacification, and here are air fluid levels as well, indicating that there's pus in the sinuses. Now, what are some etiologies? Strep pneumo, H. influenza, Moraxella. Please make sure to note that strep pneumo, non-typable H flu, and Moraxella catarrhalis are your three most common agents for sinusitis, otitis, and pneumonia. This is just speaking in the general population. However, there are special populations which I want to also hone in on, and that is diabetics. Diabetics can get this necrotic frontal sinus infection related to mucor. And remember that this is a fungal yeast-like organism. Recurrent sinusitis is important for us to integrate on the USMLE. Recurrent sinusitis, seen in patients with cystic fibrosis. Remember, they have a CFTR mutation, bad chloride channel, thick secretions. They gunk up the sinuses. Patients who have poor Dynean arms, i.e. primary ciliary dyskinesia, also known as Cartaginer syndrome. But remember, these patients don't have good mucociliary clearance and thus gunked up sinusitis. And then granulomatosis with polyangiitis. Remember, granulomatosis with polyangiitis. that used to be called Wegener's disease, but with granulomatosis with polyangiitis, they will also have hemoptysis and hematuria. With the hematuria on the USMLE, they may say abnormal urine analysis that shows RBCs. So if you get a ANCA, which ANCA will be positive in patients with GPA? Go ahead and put in the chat, C ANCA or P ANCA. What do you think is the best answer? All right, y'all are listening and I absolutely love it. C ANCA, remember C ANCA is related to anti-proteinase 3. Again, integrations, keeping this like a guided Anki deck. You're doing questions and content at the same time. Lego and go into this next question. Very good. So a 5-year-old female presents with decreased oral intake. She returned from her grandmother's summer vacation home 2 days prior. Examination notes ulcers in the posterior oropharynx. There are no exudates. Skin examinations note tender, non-vesicular lesions on the palms and soles. Which of the following comorbid conditions may occur as a result of this infection? A, bacterial meningitis. B, superimposed HSV infection. C, coronary artery aneurysms. Or D, myocarditis. What do you think is the best answer here? Excellent. Very proud of you all. If you're saying D, you're absolutely correct. Remember that this patient most likely has hand, foot, and mouth disease secondary to Coxsackie A virus. And remember that the whole Coxsackie family, both A and B, though B is more common, can cause myocarditis. We talked about myocarditis in our last session. If you haven't checked out integrated cardiology, microbiology, please make sure you check out that video on YouTube. All right. So I do want to pivot and talk about another upper respiratory tract disease, and that's pharyngitis. Remember, pharyngitis, the patient on your USMLE, fever plus red posterior portion of the mouth, red oropharynx. So you're going to be thinking about pharyngitis, putting together inflammation as well as the patient's symptoms related to inflammation, as well as the physical exam. One of the pathologies that I want to go through is herpangina. Herpangina is basically going to be ulceration of the mouth, typically due to Coxsackie A. They may put in the vignette a summer season, and it is fever and pharyngitis with gray vesicles on the posterior pharynx. Now, this is going to be slightly different than herpetic gingivostomatitis. Both of these pathologies have really inflamed mouth. However, in herpetic gingivostomatitis, it is related to HSV. You get fever and pharyngitis. The disease is usually going to be isolated to the gingiva, and you'll have red vesicles with the erythematous base, and this is typically on the anterior pharynx, not on the posterior. Remember that these have, again, an erythematous base. Another important pharyngeal integration that I want to make is related to Koplik spots. Remember that Koplik spots are going to be on the pharyngeal mucosa, as well as could be on buccal area as well. These patients are going to have most likely palatal lesions, and this is related to measles. Watch for cough, coryza, conjunctivitis, and Koplik spots in an unimmunized patient. A child undergoes evaluation at a school summer camp. The child was not feeling well yesterday at home, and this morning was noted to have a temperature of 101.3 degrees Fahrenheit. He is complaining that his throat is sore. On examination, posterior oropharynx is erythematous. There is conjunctival hyperemia. Which of the following describes the morphology of the likely etiology? A, single-stranded DNA virus. B, gram-positive Diplococcus. C, double-stranded DNA virus. or D, mRNA linear segmented virus? What do you all think is the answer here? Excellent. And I'd encourage everyone to answer. If you said that this is going to be a double-stranded DNA virus related to adenovirus, you're absolutely correct. Remember, adenovirus can cause pharyngitis and it can cause conjunctivitis. And that is exactly why I placed this question in here, to highlight both. So when we think about pharyngitis, again, you can characterize that on your physical exam as exudative versus non-exudative. Exudative means that there's pus. So they may say that there is going to be white membrane on the tonsils or on the pharynx itself. Remember that this could be due to bacterial etiologies, classically group A streptococcus. But viral etiologies such as EBV can also cause exudative pharyngitis along with CMV. Non-exudative, you're not going to have pus, and this is typically due to a viral cause. So they may just say an erythematous oropharynx or erythematous tonsils. We talked about adenovirus. Remember that adenovirus, they'll have conjunctivitis usually associated. Rhinovirus, which causes URI, influenza, as well as coronavirus. All of these can cause non-exudative viral pharyngitis. All right, let's go through this active recall question. What is the likely morphology of the virus behind this patient's symptoms? A 1-year-old male presents in November with cough. His mother was concerned as his voice sounded hoarse, and at night he had loud noises on inspiration. He presented via ambulance due to intercostal retractions and audible stridor. So again, he's in respiratory distress right here. Before we go into the morphology of the virus, what do you all think is the diagnosis in this patient? Okay, I'm seeing whooping cough, croup. Excellent. So this is most likely going to be croup, also known as laryngotracheal bronchitis. These patients are going to have audible stridor, some URI symptoms, as well as hoarseness. This is typically due to parainfluenza virus. And remember, that's part of the Paramyxo family, and it is a single-stranded negative linear RNA virus. So let's go through laryngotracheitis. Remember that laryngotracheitis refers to the fact that this is where? Upper respiratory disease, because it affects the larynx and the upper portion of the trachea. And again, we talk about croup being the short form of this. So croup parainfluenza is the most common entity. Etiologies, like I mentioned, parainfluenza. Features are going to be this inspiratory stridor, barking cough, as well as hoarseness. On X-ray, you are going to see this very characteristic narrowing of the upper airway, and that is known as the steeple sign. Now, we typically don't get AP neck X-rays in patients because croup is going to be a clinical diagnosis. However, it's important to get it because sometimes kids can present with stridor due to things like foreign body, or they could have a toxic appearance where you're worried about epiglottitis, etc. So this is going to be a summary concept web that I wanted to make related to upper respiratory tract disease for the USMLE. When we think about stridor, remember, stridor is an extrathoracic sound. It is going to be in the upper airway. Typically, stridor is going to be on inspiration. And again, where do you find this on the USMLE? In the physical exam of your vignette. Things that we talked about. Croup, remember, barky cough in an infant. Laryngomalacia is another one. This is typically redundant tissue surrounding the upper airway, specifically the larynx. And because of gravitational effect, you can hear stridor that is worse in the supine position. But then when the baby is going to be on their tummy, you don't hear the stridor anymore. So it's positional stridor. Foreign body, like I mentioned, can cause you to have stridor. Typically, this is acute onset. They may say that the toddler was playing with the older brother when they had acute onset of respiratory distress. They could say asymmetric lung exam, where you see hyperinflation on the chest x-ray, or you see decreased breath sounds on the right side, indicating the propensity of a foreign body to go towards the right side of the lung. And then finally, vascular ring. This is going to be getting into a little bit of embryology and understanding sometimes the aortic arches can malform and cause a compression of the upper airway. This is typically going to cause stridor because it's going to be a vascular ring that is going to compress the airway. Patients on your exam may have abnormal echo. However, when you extend the neck, the stridor may go away because of the relief of the vascular obstruction. All right, here's a table integration covering some of the important microbes which we have gone through. Parainfluenza. Well, strains 1 and 2 cause croup. Again, I'm giving you a little bit more detail as we go into each of these microbes. Parainfluenza can cause the common cold, as well as atypical interstitial pneumonia, and we'll talk about that coming up. You identify it as a negative strand, single-strand RNA genome. Virulence factor, similar to RSV, it's going to be a fusion protein. F protein causes syncytia of cells together. Mode of transmission, respiratory droplets. And remember, especially with patients who have croup with respiratory distress and audible stridor at rest, you give racemic epinephrine. Remember that racemic epinephrine is going to have both the alpha-1 and a beta-2 effect because it's epinephrine. The alpha-1 is going to vasoconstrict in the upper airway, and that is going to reduce the edema in the upper airway. Beta-2 is going to have mild bronchodilation, i.e., it is going to cause smooth muscle relaxation in the upper airway. We also use Decadron to reduce the overall inflammation, but there's a little bit of autonomic integration for you. RSV, it causes bronchiolitis. Now, bronchiolitis is going to be a lower respiratory tract disease. However, I did want to put it in here because RSV can also cause the common cold. Remember that this is an RNA virus. It is going to have the F protein that fuses cells together and thus causes virulence, also transmitted via respiratory droplets. And one of the important pharmacological integrations is going to be palivizumab. This is also known as Synagis. So this is given in children who are high risk, say that they have congenital heart disease or they're born premature. Typically during RSV season, they get these Synagis or palivizumab shots. And this is a monoclonal antibody that helps prevent RSV because it is a monoclonal antibody against the F protein. And hopefully then you get some immunity from RSV. Remember, it's given to these high-risk populations because if these high-risk populations get RSV, they can have pretty severe disease. Speaking of severe disease, in first aid, it's also written that RSV, you can use an antiviral known as ribavirin. Coxsackie A is going to be part of that Paramyxo family. We talked about hand, foot, and mouth disease, herpangina. Coxsackie A can cause aseptic meningitis. We also want to note here that Coxsackie A is an unenveloped positive single-stranded RNA virus. It is going to be transmitted via fecal-oral route and via respiratory. Let's go into the next question. A 5-month-old presents to the pediatric intensive care unit. The patient was born at 35 weeks gestation. He has been otherwise healthy. He has an older brother who had a cold a few days before presentation. The patient is noted to have tachypnea, intercostal retractions, and flaring of the nasal alae. There are bilateral wheezes and basilar crackles. Chest X-ray shows interstitial opacities and no cardiomegaly. Which of the following pathogens is the most likely cause of the patient's symptoms? A, Mycoplasma pneumoniae, B, strep pneumoniae, C, RSV, D, coronavirus, or E, parainfluenza virus. What do you think is the best answer here? Excellent. So remember that this is an infant who presents with lower respiratory tract disease. Specifically, they are going to have this exam that is notable for respiratory distress, as well as bilateral lung disease, which indicates that this is going to be a viral type of entity. Remember, he had a sick contact, and with bibasilar crackles, you also worry about heart failure, but in this case, the chest X-ray showed no cardiomegaly. So the best answer here is going to be RSV, and this is exactly the presentation of bronchiolitis. Infant with lower respiratory tract disease, very high yield for us to know. Typically, demographically, these children in your exam will be less than 2 years old. All right, going through some active recall questions. What would be the likely finding? A 3-year-old male presents with acute onset, fever, and tachypnea. On exam, he has stridor, drooling, and a respiratory rate of 24. A translator is used during the exam as the patient and his families have recently immigrated from overseas. The patient is unimmunized. A lateral X-ray is done. What would be the likely finding? So, in this patient, are we thinking the patient is sick or not sick? Go ahead and type in to the chat, sick or not sick? Absolutely. Very good. Sick. And this characterization is very important, just even clinically. But what's important for us to recognize here is that with the unimmunized state, this patient most likely has epiglottitis. And remember that epiglottitis is going to be due to typable H flu, which is a gram-negative Coccobacillus. On lateral neck X-ray, you may see the thumb sign, which indicates inflammation surrounding the epiglottis. The most specific physical exam sign for epiglottitis and that shows impending respiratory failure is drooling in a tripod position. Remember that these patients are going to have such bad inflammation of the epiglottis that they can't get air in. That's why it's an upper respiratory tract disease, and they are going to be holding in a tripod position to maintain their airway to be open. This is an airway emergency and requires a team effort. What may have prevented this pathology? Well, Hib vaccination. Thankfully, Hib vaccination has decreased the incidence of epiglottitis due to typable H flu. Now, remember that the Hib vaccine contains type B capsular polysaccharide, and it is conjugated to the diphtheria toxoid. And so as a result, this gives a robust B and T response. All right, let's go through epiglottitis for the USMLE. Remember, epiglottitis is due to typable H flu. And why is it typable? Because it has a capsule, okay? Non-typable H flu cause sinusitis, otitis, and pneumonia. Key features here is to note that patients will have high fever in your exam questions, drooling in that tripod position, and as you can see here, the epiglottis is very inflamed, and as a result, you are going to have airway issues as well as at times dysphagia. Lateral neck X-ray is going to show that thumbprint sign. So just to have a little bit of spaced repetition, steeple sign, parainfluenza, croup, thumbprint sign, epiglottitis, H influenza. I hope this is helping. Go ahead and type in yes if you're paying attention and you're learning stuff. Okay, Nicole, Minchu, Shanesh, Mary, Brittany, Wendy, excellent. Thank you all for joining. Let's go ahead and keep going. When we're thinking about pediatric respiratory disease. Obviously, being a pediatric ICU doctor, we see some of these etiologies pretty frequently. And I want to kind of synthesize them because these diseases are seen on your USMLE. Let's go ahead and review epiglottitis, key elements in epiglottitis questions: unvaccinated plus sore throat and drooling. We're also going to be thinking about diphtheria in unvaccinated patients. These patients will typically have sore throat, but a pharyngeal pseudomembrane. They say leathery-like pseudomembrane on the tonsils and in the pharynx. Whooping cough is also an unvaccinated state. Remember, unvaccinated state, we're going to be thinking with whooping cough, severe coughing, and post-tussive emesis. So they'll cough, 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 and then they'll throw up. And very characteristically, these patients have lymphocytosis. Remember, this is due to Bordetella pertussis, which is going to be a bacterial etiology. Typically, with bacterial etiologies, we think about a neutrophilic predominance. However, these patients are going to have characteristically a lymphocytic predominance, even though it's due to a bacteria. Acute otitis media is also important for your USMLE. Fever plus ear pain, also known as otalgia, and a bulging tympanic membrane with decreased light reflex on your physical exam. Bronchiolitis, a child less than 2 with rhinorrhea and also lower respiratory tract disease. Remember, intercostal retractions is a sign of pediatric respiratory distress. And laryngotracheitis is the next one. We talked about how this causes you to have an infant with a barking cough and stridor, laryngotracheitis, also known as croup. A 3-week-old male presents to the International Health Clinic. His mother has noted pauses in his breathing over the past week. He has had decreased oral intake as he keeps coughing. After a coughing fit, he typically has a choking sensation and has emesis. Which of the following cell lines may be elevated in this patient? A, lymphocytes, B, basophils, C, neutrophils, D, mast cells, or E, eosinophils? Awesome. If you were paying attention, you would have gotten this question right. This is absolutely pertussis. And remember that pertussis can cause a lymphocytosis. Pertussis characteristically can cause apnea as well. And that's why it can be very scary in children, because they can have defects then in oxygenation and ventilation. And this represents the post-tussive emesis. So let's do the table integration. Pertussis, it causes whooping cough. In terms of identification, it is going to be a gram-negative Coccobacillus. It does have a capsule, and it is oxidase positive. It's also going to be growing on the Bordet-Gengu potato agar. Virulence factors. This is high yield. It is an AB type exotoxin, and it increases cyclic AMP by inhibiting G protein coupled receptor I, or GI. This is via the mechanism of ADP ribosylation. And remember that Bordetella causes that lymphocytosis. The mode of transmission is via respiratory droplets, and pharmacology integrations are the following. Remember that we are going to vaccinate against pertussis via the DPT vaccine in childhood. This is an acellular or inactive whole cell vaccine. Remember that in adolescence, or if you have a rusty nail injury, you get the Tdap, which has a little bit of pertussis in it, but primarily we're doing the Tdap for tetanus. Patients who are going to get pertussis, they're typically treated with azithromycin. Azithromycin, remember, affects the 30S ribosomal subunit. This picture right here represents another physical exam finding related to pertussis and kind of help solidify that these patients on your USMLE questions are going to have severe coughing to the point where they can get subconjunctival hemorrhages. And these subconjunctival hemorrhages are just due to the increased pressure due to the severe coughing. Just to integrate oxidase positive organisms, we're talking about Bordetella pertussis, also Neisseria and Pseudomonas are oxidase positive. This is going to be a pathophysiology diagram that just kind of helps you reinforce that when it comes to pertussis, it is ADP ribosylation of the GI. And this is going to cause increased amounts of cyclic AMP downstream. Remember that cholera is going to ADP ribosylate GS. That's high yield for us to know. So when we think about pertussis, it's going to have three distinct phases, okay? Catterhall, which is going to be 1 to 2 weeks, also has mild URI symptoms. You have paroxysmal, which is going to be lasting 2 to 5 weeks. You're going to have coughs that are in succession, followed by an inspiratory whoop. And then finally, you're going to have the convalescence, which is going to be 1 to 2 weeks. And these patients have a decline in coughing. Please note that when you're treating pertussis, you are also going to have post-exposure prophylaxis in all household contacts. So not only the patient with pertussis will get azithromycin, but also the close contacts will get azithromycin. And remember that azithromycin is going to be a macrolide. And I apologize, last slide I said that they were 30S, but it's actually 50S ribosomal subunit. So remember that aminoglycosides and tetracyclines, that was my bad, 30S, whereas when you're thinking about macrolides such as azithromycin, erythromycin, that is going to be 50S ribosomal subunit. Sorry about the error. Please make sure you take a note of that. All right. We're now going to pivot and talk about lower respiratory tract disease. These patients on your USMLE are going to have disease of the lower trachea, the bronchi, which we kind of talked about a little bit related to bronchiolitis, as well as the lung parenchyma itself. These patients will have mild fever, respiratory distress, because again, the lungs are going to be affected, and they're going to have focal lung findings on your physical exam in your USMLE questions. This is going to be aside from my pass-fail course, and in particular, it is going to show you the importance of paying attention to the physical exam in USMLE questions. In USMLE questions, you may see rales and crackles, wheezing, stridor, fremitus. And I want to go through the pathophysiology as well as some of the key features that the USMLE goes for. Now, remember, these can be also those audio questions where you put headphones on exam day and you have to, you're tasked to place the stethoscope on the lungs and you're tasked to figure out what's the lung sound. So crackles usually indicate fluid or fibrosis in the lungs. This is typically heard on inspiration, especially as those small alveoli are trying to expand. Wheezing indicates inflammation of the small airways, again, lower respiratory tract disease, and bronchial hyperresponsiveness. So that is why in asthma, we see a lot of wheezing, because again, it is that smooth muscle that is kind of twitchy in that bronchial region. This is typically heard on expiration. Stridor is going to be upper airway, and it's heard primarily on inspiration. And then fremitus indicates that there's a consolidation of fluid or a solid mass. So if there is a pneumonia, i.e. a solid mass, you're going to hear the vibrations on tactile fremitus. And this is also associated with egophony whenever you have a fluid or solid mass. What is going to be on percussion? On percussion for fluid or solid masses, are you going to have delta percussion or hyperresonant? Go ahead and put that in the chat. For fluid or solid masses, delta percussion or hyperresonant? Excellent. Very good. If you're saying dull, you're absolutely correct. Hyperresonant, that's typically in our USMLE questions related to pneumothorax. Ladies and gentlemen, one of the key study tips that I will give you is to always try to differentiate various pathologies, because compare and contrast is something that the USMLE loves to test on. Very good. So let's go through lower respiratory tract disease. A 77-year-old male is brought in by EMS after awakening with fever, chills, and chest pain, worse on inspiration. He has copious sputum production. On auscultation, the patient has decreased breath sounds in the right lower lung field. What are other physical exam findings which may be present? We talked about many of them. Crackles, fluid or fibrosis, dullness to percussion, bronchial breath sounds, and increased tactile fremitus. This is your classic presentation of community-acquired pneumonia. So when we're thinking about pneumonia, this is a little bit of a pathology integration, but let's go through it. Lobar pneumonias are going to represent pneumonia that involves large portions of the lung, and typically this is isolated to a single segment. Whereas bronchopulmonary, you're going to be thinking about multifocal infiltrates in various portions of the lung. And again, this is small airway disease. And then finally, interstitial. Now, interstitial pneumonia is typically going to affect both lungs, and it's going to be at the alveolar septa. The way I like to think about it is here's the alveoli, here's the pulmonary capillary, the interstitium is going to be here in green, right in between. And so interstitial pneumonia can thicken the alveolar septae, and just to integrate some respiratory pathophys, that can cause you to have hypoxemia because you are going to have an issue in diffusion from taking P big AO2 and turning it into P little AO2. We talked about and introduced community-acquired pneumonia. Let's go ahead and just go into some frequently tested bacterial etiologies related to lobar pneumonia. Here we go. Strep pneumo. I mean, this one is very high yield, very common, gram-positive, lancet-shaped diplococci, and remember, it has an IgA protease and is encapsulated. When we're thinking about Klebsiella, Klebsiella is going to be not gram-positive, but it's going to be gram-negative. And you are going to associate Klebsiella with patients who have a high aspiration risk. So patients who are going to have strokes, maybe dementia, maybe they're going to be alcoholics. And these patients with Klebsiella may have bloody mucoid sputum. These patients are at risk of aspiration as well as lung abscesses due to anaerobes. Finally, you're going to be thinking about MRSA. Remember, MRSA is going to be related to staph. This can be a nosocomial infection, but also you are going to be thinking of MRSA or just staph in general after a prodrome of a flu-like illness. All right, so this is an exercise called Think Like the Test Maker. And what we're going to be doing is going through just a little bit of buzzwords and common epidemiology microbes related to certain populations and pneumonia. So if you have a neonate with pneumonia, you are going to be thinking about GBS and E. coli. Now, as you get from college age onwards, remember, these patients are going to then present with fever, shortness of breath, pleuritic chest pain, and sometimes sputum. Let's just say that you have a college kid who has pneumonia. This patient won't have sputum. This is atypical pneumonia. And typically, we're going to be associating mycoplasma in this population. Alcoholic plus pneumonia, you're going to be thinking about anaerobes like Peptostreptococcus, Fusobacterium, Prevotella bacteroides. These are all part of your oral flora. A patient who has a hereditary disorder, pancreatic insufficiency, and recurrent pneumonia. Again, many organ systems involved in recurrent pneumonia. You're going to be worried about Staph aureus, especially under the age of 20, MRSA, as well as Pseudomonas and Burkholderia cepacia. What about HIV plus pneumonia? And that is going to be Pneumocystis. Key lab characteristics, ground glass appearance, silver stain, and remember, we prevent and treat with Bactrim or trimethoprim sulfamethoxazole. And then finally, smoker plus COPD plus pneumonia. You can be thinking about Klebsiella, but if they give you some diarrhea, for example, as well as hyponatremia, you're going to be thinking about Legionella, another silver staining microbe. Also, you're going to be thinking about H. influenza and Moraxella catarrhalis. When we think about bronchopneumonia, remember that bronchopneumonia affects multiple lobes. And the big picture here is that it is acute bronchitis and then subsequent extension of that inflammation into surrounding alveoli. So kind of pus pouring into different alveoli, and thus you get multifocal infiltrates. When we're thinking about bronchopneumonia, you can see multiple portions of the lung that is going to be affected with those thickened bronchiolar septa, indicating a lot of inflammation there. So let's go ahead and go through this question. An 18-year-old male presents to the urgent care with fever, headache, shortness of breath, and fatigue. The patient is noted to have increased respiratory rate. The hemoglobin is low, and chest X-ray is notable for interstitial opacities bilaterally, indicating that this is an atypical pneumonia. Which of the following pathophysiologic mechanisms is behind this patient's symptoms? A, lymphocytic infiltration of the thyroid. B, splenic macrophage consumption of RBCs. C, sickling of cells in the pulmonary vasculature. Or D, cross-reaction IgM antibodies binding to I antigen on erythrocytes. What do you think is the best answer in this patient? Excellent. And thank you all for staying active and engaged. This patient most likely has walking pneumonia, secondary to Mycoplasma. And remember that Mycoplasma is related to autoimmune hemolytic anemia, particularly cold agglutinins, and that is IgM antibodies cross-reacting to the I antigen on erythrocytes. Remember that these patients may also have in test questions Coombs positivity. And the fatigue is a sign of anemia, as well as in this case, hemolysis. So when we're thinking about Mycoplasma on the USMLE, here's the breakdown. Remember that Mycoplasma has no cell wall. It actually has a cholesterol membrane. It infects the lungs and causes the interstitial inflammation. What's also notable is that certain vignettes are going to be related not only to atypical pneumonia, but this targetoid rash characteristic of erythema multiforme, and Mycoplasma can be a trigger for erythema multiforme. We also talked about IgM-mediated hemolysis. Typically, you're going to use your macrolides like azithromycin, and that is going to inhibit, like we've talked about, the 50S ribosomal subunit. And here's a picture that kind of shows the interstitial opacities that are going to be starting from the hilum and then extending out on your chest X-ray. So we talked about certain populations, and this is important, especially when you're thinking about pneumonia questions. You want to just look quickly at the demographics. Neonates are going to have pneumonia from GBS and E. coli. Remember, GBS has beta hemolysis and an antiphagocytic capsule. E. coli, like many gram-negatives, has endotoxin, and that's different than exotoxin. Endotoxin, lipopolysaccharide make that association. In children, you're going to be thinking about viral pneumonias such as RSV, atypical pneumonias from Mycoplasma, STI-related pneumonias, especially in children who are going to have this interstitial pneumonia, and they're going to give prominent coughing. You're going to be worried about chlamydia trachomatis as well as chlamydia pneumoniae. And then if they have a lobar pneumonia, strep pneumonia. As you get into the teenage years, you're going to be thinking about atypicals more. Remember your college age, walking pneumonia, Mycoplasma. STI-related, which is chlamydia, community-acquired pneumonia, as well as viral pneumonia due to influenza A. Now, let's just say we get into more middle age. This is where you're going to see more strep pneumoniae as the most likely cause of pneumonia. You're also going to be thinking about anaerobes in certain populations that are at risk for aspiration, viruses related to coronavirus, and then atypical Mycoplasma. Finally, in the elderly population, you have a similar distribution. You're going to have increased likelihood for pneumonia due to flu, and that's why elderly patients especially need to receive their flu vaccine. And then you can have these gram-negative rods, especially if they are going to be hospitalized. You're going to be thinking about Pseudomonas, for example. So let's go ahead and finish off this webinar with just a few more questions just to continue to get us active and engaged. Y'all hanging in there? Go ahead and type in yes into the chat box. Good. Excellent. Hey, thank you all. Let's keep going. We're almost done with this review. I want to be very comprehensive, so I apologize that I'm just going a little bit over time today, but let's keep going. All right. A 59-year-old female presents with fever and productive cough. The patient has a history of COPD and chronic cough. The patient smokes 3 packs of cigarettes per day, along with 1 pint of vodka she drinks. Sputum analysis is notable for an encapsulated, gram-negative, oxidase-negative bacilli. Which of the following virulence factors mediates this patient's underlying disease? A, mucoid growth. B, IgA protease. C, biofilm. D, streptolysin. Or E, pyocyanin. What do you think is the best answer here? Awesome. And if you're watching this at another time, feel free to just pause the video and try to think of the answer on your own. And this is Klebsiella. So with Klebsiella, which is a gram-negative, oxidase-negative bacilli, especially common in COPD and alcoholics, you think about that mucoid growth. And it's that mucoid growth that can also have you have that current jelly sputum related to Klebsiella. All right, let's go through this question here. A 60-year-old male presents with watery diarrhea, cough, and shortness of breath. His wife found him confused on the porch as he was out for his daily cigarette smoke break. He is febrile, normotensive, and tachypnic. Heart rate is 84. Labs are notable for hyponatremia. Which of the following entities may be responsible for his symptoms? A, gram-negative rod. B, gram-positive diplococci. C, gram-negative diplococci. Or D, spirochetal organism. You got it. Wonderful. And if you're thinking about Legionella, you are absolutely correct. Just a couple points related to Legionella. Patients typically have watery diarrhea, COPD, or patients who are going to be exposed to colonized or infected water sources. That's an important trigger. What's unique is that patients with Legionella, similar to Salmonella typhi, are going to be very febrile, but they're going to have relative bradycardia to their fever. So if you're very febrile, you should be tachycardic, but these patients have relative bradycardia. And also recognize that the patient has hyponatremia, and that could be related that is definitely, in this question, related to Legionella and one of the predisposing factors to his confusion. Last question in this triple threat. A 44-year-old female presents with sudden onset fever and productive cough. The patient has shortness of breath. The patient's vital signs are notable for tachypnea and pulse ox of 88% on room air. The patient undergoes sputum analysis that is negative for acid-fast bacilli, however, positive for an incomplete zone of hemolysis. Which of the following virulence factors is related to this patient's presentation? A, evasion of phagolysosomal fusion. B, F protein fusion. C, ADP ribosylation of elongation factor 2. Or D, evasion of phagocytosis. What do you think is the best answer here? Excellent. If you are saying D, evasion of phagocytosis, you're absolutely correct. This is going to be the classic clinical presentation of a community-acquired pneumonia. This is typically due to strep pneumoniae, which gives you that incomplete alpha hemolysis, and it has a capsule, so it evades phagocytosis. Remember that ADP ribosylation of elongation factor 2, Pseudomonas and diphtheria do this. All right, let's do the table summary from our rapid review here. Klebsiella, it can cause pneumonia in alcoholics and COPD. We'll also review it again in the renal section. Identification, it's a gram-negative rod that is oxidase negative. The virulence factors are the fact that it has a large antiphagocytic capsule. It also has that mucoid colony production. Mode of transmission, typically via aspiration of respiratory droplets. And we typically use a third-generation cephalosporin to treat Klebsiella. Legionella, it can cause an atypical pneumonia. Remember that patients may be exposed to an infected water source, have COPD. The flu-like symptoms with hyponatremia and watery diarrhea, very characteristic. It is a gram-negative cocobacillus. It is facultative intracellular, and it needs cysteine and iron, so the BCYE agar. Remember that because it's a facultative intracellular organism, it's going to grow in the macrophage. And typically on sputum analysis, you'll see in your test questions, neutrophils with no bacteria isolated, and then watch the relative bradycardia in the association with fever. Mode of transmission is aerosol, and chlorination is a public health metric, and especially related to pools that can prevent Legionella. Moraxella, we didn't have a specific question on it, but remember the three organisms that are most commonly related to sinusitis, otitis, and pneumonia are strep pneumo, non-typable H flu, and Moraxella. So I wanted to put this in here. It's a gram-negative Diplococcus, and it has an outer membrane that creates this complement evasion. Again, evasion of that innate immune response. We typically use amoxiclav and ceftriaxone because Moraxella can produce a beta-lactamase. And so we need to have beta-lactams conjugated with clavulanic acid, a beta-lactamase inhibitor, or just have a big beta-lactam ring, as in the case of cephalosporins. Strep pneumoniae is going to be probably the highest yield take-home for today. With strep pneumoniae, it can cause you to have pneumonia, sinusitis, otitis, bronchitis, and meningitis. Identification, it is a gram-positive, lancet-shaped diplococci, incomplete zone of hemolysis, i.e. alpha hemolysis. It is catalase negative, which is what ends up differentiating it from staph species, and it is optogen sensitive. Virulence factors, one of the most commonly tested virulence factors is the fact that strep pneumo has an antiphagocytic capsule. This capsule prevents phagocytosis. It also is going to be a virulence factor when patients have asplenia. Particularly related to pneumonia, strep pneumoniae has this IgA protease. Think of it as scissors that strep pneumo has, and these scissors end up clipping IgA at the J chain, and there's that immunology tie-in. Mode of transmission, aerosol and contact. Remember that we have strep pneumonia vaccines, conjugate vaccines, as well as capsular vaccines. High-risk groups, such as patients who are going to be asplenic, are going to get both of these vaccines. Patients who have diabetes, COPD, again, at-risk populations end up getting both of these vaccines. And we vaccinate children with the PCV vaccine as well as at 2, 4, and 6 months. And then finally, recognizing that we can use amoxicillin, fluoroquinolines, and ceftriaxone, amongst other agents, but these are the common ones when we think about community-acquired pneumonia treatment. So I do want to do some vaccine immunology integration. when we think about just the polysaccharide pneumonia vaccine, that is PPSV23 polysaccharide, a polysaccharide based is going to do more humoral immunity, so B cell mediated. And because there's no T cell response, you won't get any memory. And at times, these antibodies are going to have waning titers. Once you have PCV13, i.e., once you have conjugation with a protein conjugate, you get both B and T cell. And with the T cells, you get lasting immunity due to the memory response. Next question. An elderly patient presents with weight loss, cough, and bloody sputum. He has a history of type 2 diabetes, poor dentition, and prolonged oral steroid use for, quote, some inflammation in his body. He is noted to undergo a chest x-ray as his sputum culture is notable for acid-fast bacilli. What portion of the lung would be the most likely location of airspace disease? A, right upper lobe, B, subpleural region, C, right lower lobe, or D, right middle lobe? What do you think is the best answer here? Excellent. If you're thinking about tuberculosis, liking areas of higher oxygen tension in the lung, right upper lobe is the best answer. This is a snippet from my immunology section of my pass-fail course, but let's just quickly go through microbiology of tuberculosis. When it comes to tuberculosis, acid-fast bacteria, it is going to have mycolic acids, and you contract that via inhalation. Now, other key virulence factors, again, I can't stress the virulence factors enough when it comes to microbiology. Cord factor and sulfatides. Now, what these do is they decrease phagolysosomal fusion and cause a caseating granulomatous reaction. As you have the perpetuation of tuberculosis, it causes macrophage lysis and the propagation of infection. Remember, it's an aerobic bacteria, and so it likes zone 1 of the lungs, and that has a high VQ ratio, and the P big AO2 is very high in the top portion of the lung. We typically use isoniazid to treat tuberculosis. Remember, this is a mycolic acid inhibitor, and you can get peripheral neuropathy due to B6 deficiency related to isoniazid, and that's why we frequently give pyridoxine with it. So the summary here is to recognize that infection of TB can cause you to also have a walling off of the tuberculosis, which is the Ghosn complex. Patients can also get active pulmonary disease, and that can give you hematogenous spread and miliary TB. And it is this miliary TB that they can give you a gross pathology section of the liver, and you see multifocal disease areas, and that represents the tuberculosis spreading hematogenously. Now, you can also end up getting a controlled infection, and that's called latent TB. And in your exam questions, they'll put positive PPD. And some sort of stressor or immunosuppression can cause you to have reactivation, and you can get active TB, which is going to be most prominent in the upper lobe and give you caseating granulomas. There are many diseases on the USMLE that are related to granulomas. Even pneumoconioses, like borreliosis, is related to granulomas. You need to know your granulomatous diseases. Another important question that you'll get on your USMLE is related to somebody who ends up having recurrent pneumonia. Now, when it comes to recurrent pneumonia, you need to understand what are the mechanisms that they're trying to test related to recurrent pneumonia. Well, you need to be thinking about patients who have, for example, tumors or lymph nodes, or they have bronchiectasis, say due to cystic fibrosis or Cartaginer syndrome. They may also have a foreign body. And again, these anatomic issues can plug up the lungs and thus give you a nidus for infection. When you see recurrent pneumonia on the USMLE, you want to think about high-risk populations, patients who are going to have seizures that have the risk for aspiration, alcoholics, dementia, GERD, dysphagia. These patients can have recurrent pneumonias due to aspiration. Next, you want to be thinking about immunodeficiencies. T-cell immunodeficiencies like HIV, selective IgA deficiencies. Maybe they give you a question related to celiac disease. Common variable immunodeficiency, where you do have B cells present, but you have low titers of immunoglobulins, as well as aspergillosis. These patients are going to have high amounts of IgE. They can have recurrent transient pulmonary infiltrates. And then finally, when you see recurrent pneumonia on the USMLE, you want to be thinking about systemic diseases, such as cystic fibrosis, primary ciliary dyskinesia, and hemoptysis and hematuria syndromes like specific vasculitides, things like eosinophilic granulomatosis with polyangiitis, microscopic polyangiitis, granulomatosis with polyangiitis. And then finally, I do want to summarize this session talking a little bit about how I approach infectious disease on the USMLE. When it comes to infectious disease, I want to identify signs of acute inflammation. Next, I'm going to try to figure out where's the source of infection in the question. What's the clinical syndrome it's causing? Today, we talked about sinusitis, bronchiolitis, pneumonia. And then, in particular, host status. Because you want to stratify, especially with your respiratory microbiology, whether you're dealing with immunocompromised or immunocompetent. Things for us to note here is that potential pathogens related to immunocompromised hosts, we already talked about tuberculosis, but you also want to worry about Pseudomonas aeruginosa, which causes ventilator-associated pneumonia. Aspergillus, remember, these cause fungal balls on your imaging. CMV, which is a cause of interstitial pneumonia in an immunocompromised patient, as well as very classically, Pneumocystis jirovecii. And that's going to be our final point for today, is talking about Pneumocystis for the USMLE. When we think about Pneumocystis for the USMLE, here are some high-yield correlates. Remember that it is a fungal etiology with no ergosterol in the plasma membrane, and that's what kind of differentiates it. The pneumocystis attaches to the type 1 pneumocyte, causing a diffuse alveolar and interstitial infiltrate. Typically in exam questions, they're going to say PJP or PCP pneumonia is going to be staining positive on silver or GIMSA staining. And it typically affects patients who have poor T cells. Remember, CD4 count less than 200, or patients who have some sort of adaptive immune system issues, such as SCID, for example. Patients with pneumocystis, because of the interstitial infiltrates, you get hypoxemia and non-specific cellular damage, as noted by high LDH. What do we give for prevention and treatment? Well, we give dihydrofolate reductase inhibitors and dihydrooptrate synthetase inhibitors, and that typically is known as trimethoprim, sulfamethoxazole. So remember, Bactrim is going to inhibit folate. Okay. Dihydrofolate reductase shows up a lot on your USMLE. Understanding trimethoprim is one of the antibiotics that does it, but also methotrexate inhibits dihydrofolate reductase. This is extremely high yield for you to know. And that brings us to the end of today's webinar. I ask you to just stick around for 1 or 2 more minutes. I first off just want to say thank you for sticking with me today. You did absolutely awesome. And I just want to clap for you as you are studying very hard for this exam. Whenever you're talking about respiratory microbiology, try to figure out, is it upper respiratory tract or lower respiratory tract? Pay attention to that physical exam in your question as well. Special announcement today. I do want to let you know that I have my NBME Top Concepts notes both on Amazon as well as a secure PDF. If you are on the fence and you just want to try HyGuru out, get these notes and you can enroll in my free NBME Top Concepts videos. You get notes and lectures side by side. And, you know, for many of you, you may say, man, I love how we are going through questions and test taking. So I would encourage you to really join my HyGuru Pass Fail course. This 70-hour course has really great integrative material, super high yield from various question banks and NBME exams. And I would love for you to join me through that series of videos. It also has a way for you to solidify your retention through doing custom UWorld questions. And remember that this is one of the most top resources right now that students are using. I do have a test-taking strategies course as well that comes with a study plan. So if you want to oomph up your NBME scores and kind of get a one-on-one tutoring experience in the comfort of your study space, feel free to look at my test-taking strategies class. Big thank you to all of you, and I will see you in future webinars. Today, if you can just take maybe a couple minutes and share HyGuru on social media, it would mean so much to me. Also, I want to feature you and what you write on my HyGuru website. So if you feel inclined, please write me a review. All you got to do is Google HyGuru Trustpilot, and you can write a review that I can feature on my website. I want to create a community of USMLE learners, and I want you to be a part of it. So again, thank you for joining my respiratory webinar. We're going to be going through future microbiology webinars, so stay tuned. Subscribe to my email newsletter, follow me on social media, and before you leave, make sure you type in one thing that you learned, and I'd be happy to answer any questions as well.